All right, welcome to chapter 29. This chapter is going to deal with face and neck injuries and what you need to do about those at the EMT and advanced EMT level. So, we want to be able to apply this knowledge to provide basic and advanced emergency care and transport to these trauma patients or acutely ill patients that have disorders of the face and spinal cord. Um, we want to make sure that we're able to recognize nosebleeds and how to treat those. And we're going to talk about some diseases of the eyes, ears, nose, and throat. Trauma part, we're going to apply fundamental knowledge to provide basic and selected advanced emergency care and transport based on assessment and what we find. Basically, we're just going to talk about the different injuries, how to treat them, and what you need to look for. Um, you need to be able to recognize your life threats, and you need to be able to recognize spinal trauma. And that becomes important when you start talking about cervical spine management and how that trauma can manifest or grow and create other issues. We're going to talk about penetrating neck trauma, laryngotracheal trauma, and that's just trauma to the airway, spinal trauma, and facial fractures. We're going to spend a couple of minutes talking about Lefort fractures. So when we get to those Lefort fractures, make sure you pay attention. I've heard a couple of people come back from National Registry and they had questions on there about Lefort grade fractures and had to identify those. So make sure you pay special attention to that area. And we're going to talk about skull fractures and the different kinds. We're going to talk about foreign bodies in the eyes and dental trauma. So face and neck trauma are frequently subjected to traumatic forces. This trauma causes injuries, and the treatment for trauma is basically surgery or medical intervention. What we do is we just bridge that gap. Um, Face trauma and fractures to bones in the face and the skull, they're fairly common injuries. I've seen many of them in my career. A lot of them doesn't cause very much problem, and the injuries can be so severe that you end up with things like airway compromise or ultimately brain death if there's been massive trauma to the skull. Penetrating trauma to the neck can cause severe bleeding. You think of your carotid artery, your jugular vein. Um, it can also allow air to enter those blood vessels. And when that air enters those blood vessels, it can cause air embolisms, which can cause immediate death. So we want to make sure that we're treating those injuries effectively. And your main goal is to prevent further injury. Your traumatic injury is your primary injury. There's not a lot you can do about that. But where you come into play is maintaining an adequate airway, adequate blood pressure, maintaining perfusion, stopping the bleeding, those kind of things. So when we do those things, what we've done is we've prevented that secondary injury, and that's our job in trauma is to prevent those secondary. Okay, so we're going to take just a minute to talk about just some basic A&P. Um, your mandible, that's your jawbone. It's like the only bone in the face that moves. Your maxilla, that's your upper lip. Okay, and I remember this by Max Overman. Your zygomatic bone, that's your cheekbone over here. Um, it's the book has it as your zygoma. I always call it your zygomatic bone. Your orbit isn't listed, but that's the bone around your eye socket, and your nasal bone, that's your nose bone here. Um, your occiput, that covers your occipital lobe right there. Your pinea, that's the little bone for your ear. Your temporomandibular joint, that's basically your jawbone. And then here you've got your cervical vertebrae C1, 2, 3, 4, 5, 6, and the bottom one is 7. Sits right at the level of your shoulders. So here's your throat. Laryngeal prominence or your Adam's apple. That's that thing on men that kind of poke out, in the upper part of your neck. Your thyroid cartilage, that's the big cartilage right below the Adam's apple. So if you push down just below your Adam's apple, you can feel that. Your cricoid membrane, that becomes very important when you get to paramedic school because that's where we do needle cracks and surgical cracks. And then just below that is your cricoid cartilage. And cartilage is what holds your airway open. There's no real bones there. And the cartilage are ring-shaped structures that just hold your trachea open. And that's your cartilage for your trachea. And then, your trachea is the structure that goes down into your lungs. This is kind of the musculature of your neck. Um, and you need all these muscles to really hold your head up because your spine, it just sits on a point. These muscles are what supports your head. Um, big structures of the neck are the carotid arteries and the jugular veins. Arteries are red, veins are blue. Um, and then your trachea sits right in between those muscles. And you have your thyroid cartilage, right there on your trachea. And this just kind of goes to show you some different pictures, some more in-depth pictures of the anatomy of the neck. Then you have your eyeball. You have your iris. You have your cornea. Your cornea is that thin, clear layer. Um, your iris is what gives your eyeball its color. And then you have your pupil, which is the little dot in the middle. The uh, the iris controls the size of the pupil, and we said it controlled eye color, and that's right there, kind of around your pupil. Pupil's a little dot in the middle. That's how much light is allowed into and out of the eye. And then you have your lens back here in the back, and that's what reflects and refracts light to give things its shape and size and those kind of things. So your lens is kind of like your internal glasses for your eye. And then you have your vein and your artery, the optic vein, optic artery. They supply your eyeball with blood. And then the most important part is your optic nerve. Your optic nerve runs to your occipital lobe, and that's what takes what you see and allows your brain to process it. Okay? So your eyeball is located within the bony socket called the orbit. We talked about that. The oculomotor nerve innervates the muscle and carries parasympathetic nerve fibers. So, um, kind of helps you move your eyeball, helps your pupil get big and little. That's what your oculomotor nerve does. Your optic nerve gives you the sense of vision. Your optic nerve is what actually interprets or takes the interpretation of what you see to your occipital lobe. So, the inner surface of the eyelids and the exposed surface of the eye are covered by conjunctiva. And what that does is that just it's kind of like a moist covering. Um, it's a real vascular area of the eyelid that when you blink it covers the eyeball, and then when you open your eyeball is exposed. The opening in the center of the iris is the pupil. Um, for those of you who don't know, that's that black dot right there. The blue part in this picture, that's going to be your iris. So the iris gives the eye its color and adjusts the size of the pupil. And then you have your lacrimal gland that allows for tearing from the upper part of the eye. And then your nasolacrimal duct allows for tearing to go into the inside of the eye. That's why if you sneeze a lot of times, your eyes will tear up. Now you have the ear. Um, the ear is pretty complex. What it senses is the change in vibration. So the ear is divided into three parts. You have your external ear, and its job is to catch those vibrations and channel them into the middle ear, and then that sound is deciphered by the inner ear and taken by the by the nerves of the ear into the brain for decryption. Um, Couple things, you have three bones right here in your middle ear. This is what the sound waves vibrate um, that allow them to kind of move through the ear. So you have the malleolus, the incus, and the stirrups or the stapes right there in that middle ear. And then you have your cochlea, which is right behind it. And you have the semicircular canals in the cochlea. That's what really starts to decipher those vibrations and make sound. Injuries to the face and neck can often lead to partial or complete obstructions of the airway. That's probably going to be the most important thing you have to deal with. Fractured jaw, bleeding into the airway, those kind of things. And you can have facial fractures so bad that your patient is unable to manage their own airway. Talk about injuries to the nose and to the mouth. You start having nasal bleeding or oral bleeding from the mouth from those injuries, obstructions from impaled objects. Those can all compromise your airway. Broke teeth can compromise your airway. Dentures coming undone. Um, denture seal is only good for so much. I know Polygrip will let you eat corn, but Polygrip may not survive an 80-mile-per-hour accident. So those dentures can cause airway obstructions. And then you can have massive swelling from direct or indirect injury. I know one of the things that we used to do is we used to give people a whole lot of IV fluid. We've stopped doing that. But that would cause them to puff up like a fish and can cause some airway swelling. So, if you have a baseball bat to the neck, you really have to be concerned about those hematomas and those swellings into the airway and making sure that you're doing your airway management aggressively and quickly to make sure that we maintain a patent open airway through basic or advanced means, whatever the situation requires. Soft tissue injuries of the face and neck, they're extremely vascular. So a small cut on the head can bleed like all get out. Um, you know, uh, I've had people, especially elderly people, they'll fall and they'll hit their head on a cabinet or something and peel part of their scalp back, and they'll just be laying in a pool of blood. I've seen these people bleed so much they've been in shock. So small injuries, minor, like where it'd be minor somewhere else in the body, can turn into something major because of all of the vasculature and blood vessels that flow through the face and through the skull. Um, Bleeding from penetrating injuries may be heavy. Internal bleeding from blunt trauma can be very significant. This is a picture of it's almost a scalping where something has peeled the scalp away from the skull. That's going to bleed pretty bad. And this elderly person here has a really big hematoma above that left eye. That means there's quite a bit of bleeding under the skin, enough for us to be concerned about. If you see something like this, that's not quote unquote in itself a severe injury, but when you start talking about what blood vessels are involved here, what damage was done to the brain, do we have skull fractures over here, do we have any form of airway compromise, those kind of things, what nerve damage was done, and then here, when you see that hematoma, your brain automatically has to start thinking skull fracture, subdural subarachnoid hemorrhage, any of those major things that can cause major, major internal problems. So maintain a high index of suspicion when patients have closed soft tissue injury, because remember that energy from those kinematics is transferred into those organs and causes damage. And blood is a gastric irritant, so if you swallow your blood, you're probably going to vomit it up in the very near future. Facial fractures occur when the facial bones absorb energy from a strong impact, baseball bat, steering wheel, windshield. Protect the C-spine. If somebody was hit hard enough in the face to cause fractures or major trauma, assume that there was a substantial whiplashing motion or a substantial amount of energy transferred into the C-spine. So we want to make sure that we're managing that appropriately. And, look for your deep facial lacerations, pain over bones, ecchymosis or bruising, especially around the eyes or behind the ears. That lets you know that there's a brain injury or a skull fracture, basilar skull fracture. And then you have swelling, pain on palpation, crepitus, misalignment of teeth. When you see misalignment of teeth, you start thinking about maxillar mandible fractures. And that takes a substantial amount of force. So you got to be cognitive of the internal injuries that could go along with those outside injuries that you're able to see. So we've all heard of a broke nose. You get swelling, tenderness, and crepitus of the nose. Um, the nose is cartilage, so it's a little bit better than breaking a bone. However, it can cause some respiratory compromise. So if the nose is crooked, it's broke. Okay. Um, and a lot of times, the big thing with that is there's not a whole lot we can do about a broke nose, except take them to the hospital, let a physician fix it. But where we come in is we have to control the nose bleeding, and we have to make sure that patient maintains a patent airway, a good clear airway with good adequate respirations, and that's really kind of what we do for our nasal fractures. Your mandible fractures, these are your jaw fractures. Um, you know, you get punched in the jaw. Most of the time, it isn't hard enough to do it, but let your jaw pop a steering wheel in a car wreck, and you'll end up breaking your jaw. And these patients usually have to have their jaw wired together for like 6 weeks. Um, Imagine not talking for 2, 4, 6 weeks because of a broke jaw. Um, the fracture of itself is most commonly located in the angle of the jaw, and you'll have a point tenderness when you go to talk. So you'll actually be able to point to exactly where your jaw hurts. And it's going to hurt. It's going to hurt to move your jaw up and down. It's going to hurt to talk, to chew, those kind of things. And they may or may not have other injuries. It depends on what your mechanism is and what other parts of the body were affected by that energy. So here's your Lefort fractures. Have heard stories of these being on National Registry. A Lefort type 1 is a maxilla fracture. Okay, that's fracture of the upper lip. Not a huge deal, but we are concerned about it. A Lefort type 2 fracture, that's a fracture of the zygomatic, the nasal bones, the orbits to the zygomatic. Okay, a Lefort type 3, and you really can't see it from here, but it's a fracture from the orbit all the way down beside the ear, basically through the jawbone. So your Lefort fractures, the higher the grade, the worse the fracture. Um, Typically, if it's really bad, you've got like CSF leaking or something of that sort, it would be a Lefort type 3, which involves the nose, the orbits, and goes all the way down to the jaw. The Lefort 2 is more anterior, so it does not, go further back and does not really affect the skull. And a Lefort type 1 just affects the maxilla. Orbital fractures, you may have double vision or loss of sensation above the eyebrow or over the cheek. Anytime you have an upward gaze, we really want to start thinking about orbital fractures with those patients. And if they have a runny nose or impaired vision, we want to start thinking about those orbital fractures. And typically they'll have pain around the orbit bone where that fracture is. The zygomatic, these are cheekbones. We see these a lot of times with blunt trauma or assaults with a baseball bat or, face versus steering wheel. Um, you'll have the side of the patient's face that is fractured will look flattened. They won't have sensation above the cheek, nose, and upper lip. And the cheekbone, the fracture from the cheekbone can cause an upward gaze of the eye. And I just kind of remember the eye looks away from the fracture. So if you've got an upward gaze, either you've got an orbital or a zygomatic fracture. Dental injuries, we get real worried about dental injuries when it comes to airway. These different braces or teeth or bridges, crowns, they can become dislodged and end up in the airway and cause an airway obstruction or airway compromise. So the primary injury may be a car wreck where the face first the steering wheel, but secondary injury could be brain damage from hypoxia due to an obstructed airway. And remember, it's our job to prevent those secondary injuries. So we want to make sure we're aggressively managing and clearing that airway. Do your scene size up. Look for hazards. This is the same thing we've done for every illness, injury in the class. BSI PPE is my scene safe. How many patients do I have? What's my mechanism of injury? Do I need backup? And how could that mechanism of injury have hurt my patient through the kinematics or how that energy transferred or transformed within the body? Deal with your life threats. Do your C-spine. LOC, airway, breathing, circulation. Um, and remember, we talk about LOC as AVPU, but also look for changes in cognition. Are they combative? Are they anxious? Those are also considered altered mental status. We consider those in our, ABCD for our disability. What is our mental status? Um, are we effectively managing our airway? Have we controlled all major external bleeding? Are we treating for shock if we need to? And remember, if you've got teeth or vomitus in the airway, you're going to have to suction that stuff out and get that airway clear. Um, Frequently assess breathing and make sure the patient is breathing adequately. If they're breathing adequately and it's major trauma, they'll get a high flow oxygen non-rebreather. If they're breathing inadequately, you're going to immediately go to your bag valve mask. And if the patient can't maintain their airway, you want to make sure you put an oral airway in, especially if they're unresponsive and they've got a deformed face from fractures, or they're having issues keeping their airway open. You're going to want to use your oral airway, as long as they don't have a gag reflex and they're not going to vomit all over the place. Rapidly transport these patients to a hospital that can handle them, hospital with plastic surgery, orthopedic surgery. And remember, if you can't manage the airway, you're going to the closest hospital to get that airway managed. Keep your scene time to less than 10 minutes. Remember that Platinum 10. Get off scene. And if you have a long transport time, definitely consider air transport for your critically injured patients. Um, get your history. Investigate the chief complaint. Be alert for injury-specific signs and symptoms. Your raccoon eyes are your battle signs for your basilar skull fracture, your CSF leaking for skull fractures, and your Lefort fractures, and those kind of things. Make sure you're kind of honing in on what those injuries could be and those effects to the body and how that affects perfusion and airway and the normal actions of the body. Get your sample history. You really want to know what's going on if they take medicine. Be acutely keen on blood thinners and medications that end in OLOL. Those are your beta blockers, your metoprolol, your labetalol, and those mask the signs of shock. And your blood thinners, you just need to keep in mind that minor injuries can become major injuries if your patient's on blood thinners. If significant trauma is likely to affect multiple systems, do your rapid trauma assessment with your DCAP BTLS. Remember, that's deformities, contusions, abrasions, punctures, penetrations, burn, tenderness, lacerations, and swelling. Make sure you have that mnemonic memorized. Do not delay transport to do a thorough exam. All we're doing with our really really bad trauma patients, or trauma patients with significant mechanisms of injury, we're doing a rapid trauma assessment and getting off scene and going to the hospital. The only time that we're going to stay and play with a trauma patient if it's an isolated injury, and the example I use is football player steps in a hole, breaks his ankle. Okay, we're going to stay on scene and splint that. Football player is plowed over or clotheslined down, has a period of altered LOC and has a fractured ankle. We're loading and going with that guy. So make sure you're able to make the determination of when to stay and play. If there's any possibility of any severe underlying injuries, get off scene. Make sure you control bleeding and maintain a note of the injury location. You want to be able to report that to the hospital, and you want to be able to go and reassess that on your reassessment. So make sure you're keeping up with the injuries that you see and that you fixed and that you splinted, and keep it kind of in the back of your brain where they're at, so as you can go back and reassess. In a responsive patient with an isolated injury with no real mechanism of injury, focus your exam on the patient's complaint, injury, and region affected. Okay? So for the isolated fractured ankle, for the isolated got hit with a baseball bat in the kneecap, we're going to really, really stay and play with those and make sure we splint those real good. How about baseball bat to the abdomen with bruising? Okay, that's a load and go because that's internal bleeding. That's affecting multiple systems. So that's going to be your load and go trauma patient. Do the facial bones seem to be in alignment? If they're not, something's probably broke. significant amount of trauma. Does the nasal bone seem deviated? If it's deviated, it's broke. Does the mandible appear deviated to one side or the other? Is the patient able to talk and open their mouth? Those are questions you need to be asking yourself as you're treating these patients, and that'll clue you in as to the extent or severity of the facial fractures. Make sure that you're quantifying your patient's oxygen and circulatory status. We want to maintain adequate blood pressure and adequate oxygenation. We want to monitor our blood pressure with our normal blood pressure cuffs. If you have an ultra-mental status, make sure you check a glucose level, because sometimes that low blood sugar will cause the situation that created the fall that broke the face bone. So we want to make sure that we're ruling out our medical stuff as well. When you do your reassessment, redo your primary assessment. Make sure you're assessing vital signs every 5 minutes on your critical patients, every 10 to 15 minutes on your non-criticals. Recheck your intervention. If you even think there's a spinal cord injury, go ahead and completely immobilize your patient with a long spine board C-collar and a cervical mobilization device. Make sure you got them on that long spine board strapped down like they're supposed to be. And if the patient has signs of hypoperfusion, make sure you treat that aggressively. At the basic level, high flow oxygen, lay them flat, keep them warm. At the advanced level, on the way to the hospital, go ahead and start your two large bore IVs and give your fluid boluses as indicated. You want a blood pressure 90 to 100 for controlled external bleeding, 80 to 90 for uncontrolled internal bleeding. And make sure if you see it, you fix it. Okay? So we start with our airway. If the airway is compromised or not clear, clear it. If the patient's breathing inadequately, breathe for them. If you see major bleeding or shock, treat it, fix it, stop it. Communication and documentation. This is where you do your run report. You want to be very accurate with your run report. You want to document the speed of the vehicle, where the damage was, how the patient was removed from the vehicle. You want to document how much blood was lost on scene, and call your trauma alerts early. That way the hospital has time to get their teams in. And document. A lot of what we're doing as far as treatment and changes in EMS occurs from going back and reviewing run reports and comparing treatment and then looking at patient outcomes. To where when I first got in EMS, we filled our patients up with fluid, had blood pressures of 120 over 80 rolling into the trauma center. They were bleeding pink Kool-Aid, in 3 days they were dead. Versus if we would come in with a blood pressure between 80 and 90 and have maintained some of that hemoglobin, that oxygen carrying capacity of the blood, the same patient with the same complaint in basically the same condition, just with less IV fluids, had a better chance of survival and walking out of the hospital because we did not deplete the oxygen carrying capacity of the blood. So soft tissue injuries, we got to focus on protecting that airway. You lose the airway, you lose the patient. Usually ABC, airway, breathing, circulation. Disability, that's your mental status changes, and environment. We want to make sure we're keeping them warm. And remember, we really want to handle that hemorrhage, that extenuating hemorrhage, very early in the process. Use a jaw thrust maneuver to open the patient's airway. We don't want to do the head tilt chin lift in case there's cervical spinal injuries. Suction the airway if you need to. Use your adjuncts to hold that airway open, and control bleeding by holding direct manual pressure. If you're bleeding in the airway, not a lot we can do about it except for try to control it with direct pressure. I mean, you can't put a tourniquet around somebody's neck. So we really, really have to pay attention to where they're bleeding from, and if at all possible, try to stop that bleeding. That's going to be your biggest threat to the airway. Cover exposed parts with a moist, sterile dressing. Treat facial lacerations and avulsions as you would any other soft tissue injury. So these lacerations we're just going to cover with gauze and wrap them up. If the face is laid open and tongue's hanging out or whatever, that's when you would use your moist, sterile dressing. If brain tissue is coming out of a hole, you want to use the moist, sterile dressing on that. Check for bleeding inside the mouth. That's going to be your airway threat. Look for broken teeth, lacerations to the tongue. And you want to make sure you're clearing those upper airway obstructions so we can have that open patent airway. Soft tissue injuries. Wrap portions of a vole skin that have become separated in sterile dressing. We're going to treat this just like we would an amputation. We want to keep that a vole skin flap. We want to kind of keep it moist and keep it cool. And do not place it directly on ice. So we're going to do the same thing we do with our amputations. Wrap it in a moist dressing, keep it cool, but don't place it directly on ice. Injuries to the eye. These are kind of tricky to deal with because a lot of times you don't know they're there. You'll have somebody with broke glasses that get fragments of glass in their eye and things, and then we have impaled objects. But what our job is to manage pain and try to maintain vision. Um, that can be a little more difficult than what you would think. Managing the pain is not so much a hard thing for paramedics because we give them pain meds. Advanced EMTs, you could use some nitrous oxide, but maintaining vision is difficult because we can't fix the primary injury. But there are some things that we can do to kind of help out with that. You want the pupils to be equal, round, reactive to light. What the left pupil does, the right pupil should do, and what the right pupil does, the left pupil should do. So if you shine a light in the right eye, both pupils should constrict. When you remove that light, both pupils should dilate. Okay, your pupils should be around 5 millimeters in size, um, and they should be quickly reactive to light. Abnormal pupil reactions could be a head injury, a brain injury, or an injury to the eye. Treatment starts with a thorough examination. Do not aggravate the problem. Okay, um, we're not going to irrigate an impaled object. But if we have a loose piece of trash, we'll take some saline and just wash that eye out. Same concept we do with chemicals, but we want to make sure that we're not going to aggravate the condition. Foreign bodies in the eye, the way you handle that is you stabilize them, same way you do with a foreign object in the leg with some cling, some tape, whatever you got. Just stabilize it so it don't move. Here's the kicker, cover both eyes. Okay? Because if your right eye starts looking around, you got a pencil in your left eye, the pencil is going to start moving because you're going to move both eyes at the same time. So stabilize the object, cover both eyes, gently irrigate. Will not wash out a foreign body stuck to the cornea or lying on the upper eyelid. We do not go pull stuff off of the eye. If it don't wash out, we let a doctor do it. Okay? And then bandage both eyes with a soft, bulky dressing. Wrap both eyes up really well. That way the patient doesn't have the tendency to start looking around with one eye. And once they start looking around with one eye, that other eye is going to follow. Burns to the eye. Same concept that we use for, a normal burn. Stop the burning process, prevent damage. Irrigate the eye with water or sterile saline for 15 to 20 minutes. And if you have to do both eyes, use a nasal cannula and hang a bag of saline, and it'll run into the corners of both eyes. You always want to irrigate the eye away from the nose. You don't ever want to push those chemicals back into the face, and you don't want to push contaminated stuff from one eye across the nose over into the other eye. So you want to make sure you're flushing from the nasal area outward and letting that saline run down the side of the face. Burns to the eye. This says irrigate for at least 5 minutes for a chemical burn. We're doing 15 to 20 minutes in the field. Local protocols on whether to try to irrigate the eye while transporting or staying on scene. You can do that either way. Typically normal saline through a nasal cannula. You can hang that and do that going down the road. Just put a towel around their face to catch the water. So irrigate for at least 5 minutes. We're doing 15 to 20 minutes in the field. These are just some injuries to the eye. Looks more like some burns to the eye. And those are going to cause some vision issues. And just looking at those eyeballs, those patients will probably never see again. So after you irrigate, clean and dress the eye, transport the patient promptly to the hospital for further care. If it's an isolated burn to one eye, you don't cover both eyes, but if there's an object or an impaled object in there, you would want to cover both eyes. Thermal burns to the eye. This is from like fire or steam. Okay, here you've got the eyelid that has been, looks like it's pretty much burnt off. So that's going to cause drying of the eyeball itself. So you're going to want to make sure that you're giving some eye drops or some saline to keep those eyes moist. Provide prompt transportation of these patients without further examination. The longer they're out of the hospital, the more likely it is they're going to lose their sight. They'll probably actually come in and do a skin graft and replace that eyelid almost immediately. And cover both eyes with a sterile dressing. Moisten that dressing because you want to keep your eyes moist. Dry eyes equal bad eyes. And that's going to cause irritation and could actually lead to blindness. And you can have light burns. We see this a lot of times with welders. That's why welders have to put that shield over their face and really eclipse that light. But the infrared rays, eclipse light, laser burns can all cause significant damage to the eyes. The burn is not painful initially, but it usually begins to manifest itself 3 to 4 hours later. This is why your parents said, don't look directly at the sunlight because those infrared rays will hurt your eyes. Severe conjunctivitis usually develops with redness, swelling, excessive tear production. Same concept with a burn, your eye gets really inflamed. Ease the pain by covering each eye with a sterile moist pad and an eye shield. You want to shut the light off. The light will cause more pain, and rapidly transport them to a hospital that can take care of them. These are lacerations. These are going to have to be repaired by a plastic surgeon. So your eye lacerations really need to go to the hospital. You don't want to apply pressure to the eye. You're not going to lose enough blood from your eye to cause shock or any major problems. Loosely cover it with like a 4x4 or something, but don't go put pressure on the eyeball. Okay? If part of the eyeball is exposed, the stuff inside the body always gets wrapped with moist, sterile gauze. Okay? You want to try to keep it moist. Cover the injured eye with protective metal eye shield. We don't carry those. We typically use sterile cups or sterile dressings to cover that eye. The big thing is you just don't want anything to be able to poke it or cut it or make that injury worse. So you're going to make sure we've covered that eye. Apply soft dressing to both eyes and provide prompt transport. Especially like here, the eyeball has jumped out of the socket. So we would cover that with a moist sterile gauze and then wrap that with a soft bandage. And on this one, we would wrap both eyes because we don't want both eyes moving around. Okay. That's a pretty good little head injury. I don't really know where his eyeball is in that, but homeboy ain't gonna make it. That's like brain tissue. Skull is avulsed, but you can see the bruising around the eye. That's called periorbital ecchymosis. That's a key indicator that there's a severe skull fracture. Blunt trauma to the eye can cause hyphema. That's bleeding in the eye. Your job is to cover it up, protect it from further injury, and transport the patient to the hospital. What we get concerned with bleeding in the eye is the pressure on the optic nerve. We don't want that optic nerve to become hypoxic and begin to die. So orbital fractures, you can see here that's your upward gaze. Anytime you see an upward gaze, you really want to start thinking about orbital fractures. Really, all you can do is immediately transport them to the emergency room, kind of help them with pain, and cover that eye. And the reason you cover the eye is you just want to prevent any further injury. And if there's a lot of movement with the other eye, go ahead and cover both eyes. The more the patient moves that eye, the greater risk that they're going to be at for injury. So you want to make sure you cover both eyes. Retinal detachment is painless, but they'll have like flashing lights or specks or see spots. If they want to keep their vision, they need to get to an optometrist immediately. So for retinal detachment, you're going to want to immediately get them to a eye doctor. And how retinal detachment happens, we see this a lot of times with like boxers and MMA fighters. Consistent trauma to the face or real hard trauma to the face will cause the retina to detach and cause real blurry, splotchy vision. Eye injuries following a head injury, you'll have like the picture. It's got one pupil that's dilated and one pupil that's normal. That is from the increased pressure in the skull. Anytime you see that stuff, you want to suspect that there's some kind of pressure on the brain. Pressure on the brain leads to pressure on the optic nerve and the optic blood vessels, which decrease perfusion to the eye. So you can kill the nerve, kill the blood vessels, and the patient may live, but they'll be blind. For an unresponsive patient, keep the eyelids closed. This will keep the eyeballs perfused and moist. And drying of ocular tissue, if you leave their eyes open, they'll dry out and they can go blind. So if the patient can't close their eyes, make sure you're covering their eyes with a moist, sterile gauze. We talked about blast injuries. Now, blast injuries, the one of the things you see is the pressure wave blows out the eardrums and can blow out the eyeballs. So, depending on the pressure that was put on the body, depends on how bad it's going to be. But in phase one, you've got the pressure wave. It can burst the eyeballs, blow up the eardrums. Phase two, you've got the flying debris, which can get embedded into the eye. Phase three, you have the fire, the where you're thrown into something, and then phase four, the quaternary injury, you have the heat, so you can have impaled objects from phase one, you can have the pressure wave that ruptures the eyeball and the eardrums. Phase two, you could have the impaled objects from the flying debris, and phase three, probably not going to hurt your eyes flying through the air, but phase four, when you get to the heat, the fire, the chemicals, you can also have eye burns. So those blast injuries can be very devastating to the eyes. So use a clean cup to protect the eye. If only one eye is injured, follow local protocol. If both eyes are injured, cover them up, cover both eyes. Big thing is you want to cover both eyes to prevent the eye from moving and the increased injury. Contact lenses and artificial eyes. People with glass eyes or fake eyes, their pupils will not dilate. So you will have one pupil that will not react to light. So that's a question you may want to ask if you're assessing your patient is, do you have a glass eye? Contact lenses, we do not remove the lens from an eye that has been injured. That's not our job. Um, to remove a hard contact lens, you have to have a small suction cup that's moistened, and you moisten the end with saline and poke it in the eye and pull that hard lens out. The soft lenses actually conform to the eye. If the eye's not injured, pop that bad boy out. But if it's injured, say the glass is impaled in the eyeball, we're not going to pull that out. We're going to let a doctor do that. To remove the soft lenses, you put a couple drops of saline in the eye and then just peel that lens off with your fingers. That's a little tricky. I've never had contacts, but my wife does, and I see her take hers out, and I don't know that I would be coordinated enough to do it. So injuries to the nose are characterized based on the bleeding area. Okay, anterior nosebleeds come from the septum, and they bleed fairly slow. Posterior nosebleeds are severe, and that's what will get blood into your throat. So posterior nosebleeds we see a lot of times with people with really high blood pressures. Anterior nosebleeds is typically caused from digital trauma or picking your nose or jabbing a pencil up there. We see the anterior a lot of times with kids, posterior a lot of times with elderly people. Um, Picture the inside of the nose itself to help in the assessment. So, kind of think about where it might be injured, what might be going on. Assess all the structures of the nose. So you want to take a good look, make sure you do a real good assessment. And, here's what your nose looks like. Air goes in. You have your turbinates here, which, cause turbulence, humidify, and kind of take some of the bad stuff out of the air. Your frontal sinus is that's the part that the doctor taps when you have a stuffy nose. It's just to the right or left of the nose, right beside that cheekbone. And then the septum is here. It runs right down the middle of the nose. So, do I have a septal injury? Do I have an injury in the area of the turbinates? Am I bleeding from my sinuses? Those are questions you need to ask yourself. Epistaxis is a nosebleed. Okay. Following facial trauma, it can be severe. This kid's probably got a nosebleed literally from picking his nose. That's the number one cause of nosebleed is some kind of internal trauma. It's most effectively controlled. What you want to do is you want to take 4x4s, pinch the nose on either side, have the patient lean forward and put their chin on their chest. Throwing your head back, that just causes you to vomit blood. Um, and if that doesn't work, you can apply pressure to the upper lip right here. The vein and the arteries in the upper lip are the veins and arteries that handle blood flow to the nose. So you can hold pressure on that nose, chin to chest, and then put, significant pressure right on that upper lip, just below the nose, and that'll help control bleeding. Abrasions and lacerations to the nose, apply a sterile dressing, and apply a little bit of pressure. Usually fixes that bleeding right up. So ear injuries, we don't see a lot of these. Typically, our ear injuries are from a change in pressure, and that can be from ascent or descent when diving or flying, or it could be from a blast wave or something like that. We also get ear injuries from infection. Those will cause the eardrum to pop. Now, externally, the external ear is exposed to quite a bit of trauma. We've seen people cut people's ears off, avulsions, ears get caught, earrings get caught and get ripped out. Apply pressure. If that does not control the bleeding, apply a roller bandage. Do a real good pressure bandage, because we can't put a tourniquet around the neck. Stop bleeding in the head. This don't work. If the pinea is partially avulsed, try to realign the ear and then wrap it up. Anytime something's avulsed, we want to try to realign those parts and wrap them up so they can maybe maintain blood flow. And we don't move impaled objects in the ear. We stabilize those in place just like we would with any other type of impaled object. So here's a picture of a massive ear injury. Foreign bodies we're not going to manipulate. That almost looks like a piece of metal sticking in the ear. We're just going to stabilize that in place, kind of like what they're doing here. Wrap it up, stabilize it, and transport them to the hospital. Not going to pull anything out of the ear. And it's going to be very painful. And just remember that little ear injury could distract from a massively broken bone or internal bleeding, because it's going to hurt the worst. So your facial fractures, do you have bleeding from the mouth? Can you swallow? Do you have absent teeth? Is your face movable? The bone fragments of your face, are you able to move those? If not, you want to really suspect your facial fractures. Here's an example of some teeth missing. That's what happens when they wire it back shut. Facial fractures alone are not acute emergencies unless there's serious bleeding. It's going to require plastic surgery. And this is fixed. The plastic part, the putting the face back together, that's the last thing they do. They're going to fix the internal bleeding, the head injuries, the fractured femurs. They're going to fix all that first. And then you're going to go to plastic surgery, and they're going to put your face back together. It could be 7, 10, 12 days after the injury before they even start working on making you look like you were supposed to again. Oral and dental injuries. Blunt mechanisms typically result from MBCs, or getting punched in the face, some kind of direct blow to the mouth or chin. You always want to assess the airway, make sure that's handled, make sure the patient's not going to aspirate or choke on their own blood. Suction that airway as needed, remove the teeth, get that airway clear, apply direct pressure to control bleeding. Same thing we do for every other injury. For severe bleeding with inadequate ventilation, suction the airway for 15 seconds, ventilate for 2 minutes, and then suction the airway again. A lot of times it is impossible to manage that airway using basic techniques. This is where you would want ALS to come in and let's get an advanced airway in place. If there's an object impaled in the face, leave it and stabilize it unless it messes with the airway. Okay, if it messes with the airway, you're going to have to remove it. The only other time you remove an object is if it affects CPR. When dealing with an avulsed tooth, handle it by the crown. Don't touch the root. Don't allow it to dry. You want to put it in like normal saline or milk or something and keep that tooth moist. So maybe when you get to the hospital, they might be able to poke that tooth back in. Injuries to the neck. Any injury to the neck is serious and should be considered life-threatening. Once the cartilage of the upper airway and larynx are fractured, they do not spring back. That's why if you punch somebody in the throat real hard, their trachea will collapse on itself and they will suffocate. Once you collapse those cartilage rings, they don't just bounce back. You can lose your voice, difficulty swallowing, fatal airway obstruction, and a lot of times you'll get subcutaneous emphysema or air will actually leak into the tissues of the neck and to the chest. So if you see subcutaneous emphysema, assume that there's some kind of airway or some kind of neck trauma. Talked about the subcutaneous emphysema. Your job is to maintain the airway. If the airway is difficult to manage, which it's probably going to be, you're going to want to get your ALS intercept so we can get an advanced airway in place. And any incident involving the throat may have injured the C-spine, so make sure you're stabilizing that C-spine. Because remember, our goal is to prevent further injury or damage. Penetrating injuries to the neck can cause profuse bleeding from laceration, the carotid arteries, and jugular veins. What we would do for this is we would stabilize that in place and rapidly transport them to the hospital. She's got a little bit more trauma going on. You see that bruising around the eyes, those swole up eyes? That's indicative that there's some kind of brain injury. If this knife has got the jugular vein or the carotid artery and we pull that knife out, she's going to instantly bleed to death. So we want to make sure that we're stabilizing that knife in place. And then you got to be concerned about an air embolism. If you've got compromise to the carotid artery or jugular vein, you may end up actually sucking air into the vascular system, which is going to cause an air embolus, which is going to kill your patient. So anytime you have a neck wound, use your occlusive dressings to seal those up. And just a tidbit, if you have somebody with a shunt in their neck and they're bleeding, or they've just had recent, I call it roto-rooter surgery, and they've had those neck veins cleaned out, Vaseline gauze actually works really good to control bleeding from dialysis shunts and neck injuries. So if you've got a laceration to the neck, you are going to put an occlusive dressing on it anyway. So stick you some Vaseline gauze on there. For some reason, it helps clot that bleeding. And watch for swelling, expanding hematomas, especially in the neck, because that will cause pressure on the airway and cause respiratory compromise. And don't, try not to constrict the vessels and the structures of the neck. If you're having to put pressure on it and you start constricting those vessels, you're going to compromise circulation to the spine, and you can even collapse the airway if you're putting too much pressure on that neck. Apply pressure above and below the penetrating wound to control life-threatening bleeding. Don't remove the impaled object. Ensure the airway remains open. Always give these patients high-flow oxygen. That way, if you do lose the airway, they are super oxygen saturated, and you wash that nitrogen out and gave them a kind of a more lengthy supply of oxygen. And make sure you obtain vascular access if you're at the advanced level. You're going to want your 2 large bore IVs, and you're really going to want to be prepared to treat these patients for shock. Laryngeal injuries. This is injuries to your airway. Your neck strikes the steering wheel, you get punched in the throat. Handlebars, if you get thrown off a motorcycle, or this says snowmobile, but we don't have those down here. You catch a clothesline. You're riding and you get clotheslined in the neck by something on a motorcycle or four-wheeler. And then you have penetrating or impaled objects in the larynx. They should not be removed unless they interfere with CPR. Try to leave those in place. Stabilize them. If they're obstructing the airway, obviously you have to remove them, but that's our last resort, is to remove that object. Signs of larynx injuries are respiratory distress, hoarseness, pain, difficulty swallowing, swallowing blood, cyanosis from the decreased oxygenation, pale skin, coughing up sputum, or sputum in the wound. If you see mucus coming out of that wound, that's probably coming from the airway. Subcutaneous emphysema, or your Rice Krispies under the skin, means air is leaking under the skin. And bruising on the back of the neck can all be signs of laryngeal injuries or injuries to the larynx. And the larynx is your voice box. So you want to provide oxygenation and ventilation, immobilize the C-spine, keep your eye on maintaining that open, patent airway, rapidly transport them to the hospital, and make sure you have an ALS intercept coming, because even though the patient may not have respiratory compromise now, in the next 10, 15, 20, 30 minutes on your way to the hospital, when that inflammation starts and that swelling starts, your patient may develop respiratory compromise and be in need of immediate intubation. And then you have muscular injuries. Most of the non-penetrating injuries are sprains or strains. You've heard of people who have sprained their neck. You have a whiplash injury. Those are injuries to the muscles. If you have whiplash or a muscular injury, high index of suspicion that there's C-spine trauma, remember your skull just kind of sits on the point of your spine. Um, Not a lot of support there. Your muscles are what gives your skull all of its support. Make sure you take them to the hospital, get some x-rays. Make sure there's no C-spine fractures. It is not your job at any level of EMS to tell anybody what their injuries are. You are not qualified. And in fact, physicians, the first thing they do is get x-rays and CT scans. We don't have that capability, so your job is to take them to the hospital and protect them from secondary injuries. Make sure you're addressing airway, ventilation, oxygenation, and C-spine concerns to prevent those injuries. Your management should focus on preventing further injury by restricting motion, manage C-spine, check your distal pulses, do your pulse motor sensory function, check your spinal cord function. And if the patient's reporting neck pain, they should be evaluated for occult injuries or injuries that's not immediately noticeable, because failure to find those injuries will result in long-term issues for these patients. So, we want to prevent as many injuries as we can. Helmets, face shields, mouth guards, sports safety wear. People wear helmets when they skate, when they ride bicycles, when they play football, mouth guards, those kind of things. That safety equipment will help prevent injury. We're working on better seat belts, better airbag systems. Every car every year is safer than the one from the last year. When I first got in EMS, we had a lot of traffic fatalities. And as time has rolled on and those older cars have gotten off the road, we're seeing our horrible accidents result in less and less fatalities. Improved headrest can reduce the number of neck strains.